بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وآله وصحبه أجمعين. My topic today is about wondering what causes hepatosplenomegaly. Not always malignancy. It's a little weird title. Okay. So as we know, we have a lot of long list of differential diagnoses for hepatosplenomegaly. Mainly, it is everything, all the medicine, So if hepatosplenomegaly is combined with fever, we know that we should think about infection. If there is jaundice, anorexia, vomiting, we should look for liver diseases and cirrhosis as well with portal hypertension. If the patient have a history of recurrent jaundice, we have again to think of liver disease and hemolytic anemia. Dyspnea, difficulty in feeding, we should think about cardiac problems. And for delayed development in children, we have to think about carbohydrate and lipid storage disorders. And if there is family history of genetic disorders as well, this will make us think more about those diseases. So the most common important storage diseases we have to think about it when we see a patient with hepatosplenomegaly. From a metabolic genetic point of view, we have the lipid storage disease. The most important are Gaucher disease and Niemann-Pick disease, gangliosidosis, mucolipidosis. We have another category which is called mucopolysaccharidosis. Hurler and Hunter are mucopolysaccharidosis type 1 and 2. We have glycogen storage disease, mainly type 4, and we have amyloidosis. Going to the target, I will mention two case scenarios. The first case is from my patients, actually. The first case is 4 years old Saudi boy, referred at the age of 1.5 years with history of abdominal distension and constipation over the last 2 months before presentation. Seen in private hospital before and found incidentally to have low hemoglobin of 4 and platelets of low platelets, also thrombocytopenia. It was 51,000, but white BCs was normal. He received twice blood transfusion because of low hemoglobin. No history of major problems like in ICU admission, surgical procedure, no history of traveling abroad or contact with sick people. Developmentally, he was totally normal, and regarding family history, the parents are first cousins, and they have 2 other normal siblings with no similar problem in the family before. So this is my patient. They brought him to our hospital for further workup, and you can see in examinations wearing eyeglass, although he's a little boy. He was well and active, but has mild pallor and stable vital signs. Normal growth parameters. He was wearing eyeglass because of refractory error, and he has strabismus. No dysmorphic feature, as you can see, but his abdomen looks distended. He has significant hepatosplenomegaly, 3 and 5 centimeters below costal margins, respectively. Other systemic examination are unremarkable. We have done bone marrow biopsy that showed hypercellular bone marrow in many cells with wrinkled tissue paper appearance. You can see it, the arrow side, and this is what we call Gaucher cells. We proceed to enzyme assay, and they found the enzyme assay showed low activity of beta glucocerebrosidase activity. And we proceed to molecular testing that showed homozygous mutation at GBA gene. This is the mutation, the leucine to proline at 483 position, which is a frequent pathogenic missense mutation that confirmed Gaucher disease. Patient started immediately on enzyme replacement therapy, and he is on it up to now. And we referred the patient to multidisciplinary team specialties to take care of his problems, other problems. So starting with Gaucher disease, it's a multi-systemic inherited lysosomal storage disease with variable degree of involvement of central nervous system. It was first described in 1882 by French dermatologist Philip Charles Gaucher. He described a woman, 32 years old, with big splenomegaly, and they thought at that time that it is splenic cancer. Later on, in 1965, the true biochemical nature of Gaucher disease was understood. And the gene that caused a mutation in GPA gene caused Gaucher disease, which located on the long arm of chromosome 1. This disease is inherited. It's an autosomal recessive inherited disorders. The parents should be carrier, and there is a chance of a 25% chance of having Gaucher disease in each pregnancy, another 25% chance of having normal child, and 50% chance of being carrier like both parents. So what's the problem in Gaucher disease? Deficiency of glucocerebrosidase enzyme, or what another name, acid beta glucosidase enzyme, will make this problem. If it is absent or it has low activity, it will lead to deposition or accumulation of glucosyl ceramide in the reticuloendothelial system, the monocyte and macrophages. This will cause the problem in every tissue in the body, mainly in the liver and spleen, bone marrow, and brain as well. So the frequency of Gaucher disease is 1 in 40 to 50,000 live birth, but in Ashkenazi Jewish, you know that it's higher. It's 1 in 850 birth. And up to now, up to date, they discovered above 400 mutation in GBA gene. And the most common mutation in 90% of Ashkenazi Jews and 50% of non-Ashkenazi are those 4 mutations. There is, of course, a genotype-phenotype correlation. The one before the last one is responsible for predict the Gaucher disease type 1. And the second one, which is positive in my patient, predict Gaucher disease type 2 and 3, or the neurological type. There is more mutation discovered, and it causes lethal type, perinatal lethal Gaucher disease, and also the heterozygous mutation in GPA gene is one of the most genetic risk factor for Parkinson's disease and dementia with Lewy bodies. So those are the 3 types of Gaucher disease. Type 1 is non-neuropathic, and the incidence, as I have mentioned before, it present at any age, and the lifespan is variable. There is no CNS involvement, but mainly there is visceromegaly, hematological abnormality, and skeletal abnormality, mild to severe. For the second type 2, it's a neuropathic type, but it's acute problem. It appears in infancy. It's less common than prevalent than type 1. It present in infancy. Usually they die. It is rapidly progressive, and they usually die by the end of the 2nd year. They have very severe CNS manifestation, visceromegaly, severe hematological abnormality, but thank God they don't have skeletal abnormalities. For type 3, it's the same like type 2, but it's more slow, chronic, slowly progressive disorder, and they usually present in the childhood, and the patient can survive up to 4 decades of his life. And all the manifestation range from mild to severe. And there is skeletal abnormalities as well. So in the clinical presentation in adult, there is general symptoms like fatigue, easy bruising, bleeding, menorrhagia, especially which is in female, decreased appetite, abdominal pain, and the most common problems they face is the hepatosplenomegaly. As you can see, splenomegaly 87% and hepatomegaly 79%, thrombocytopenia, anemia, and they have bad problems in their bone. They have bone pain, bone crisis, pathological fractures, collapse, joint collapse, osteonecrosis, osteopenia, all are due to bone marrow infiltration with toxic materials. And they are liable to develop Erlenmeyer flask deformities, and you can see it by radiological studies. What about the clinical presentation in children? They have more aggressive disease. They have marked splenomegaly. This is the landmark for it in pediatric age group, easy bruising and bleeding, delayed puberty, and growth retardation. And the most common presentation is hepatosplenomegaly, massive splenomegaly actually, in 95% of patients, and 87% it's hepatomegaly, due to hepatomegaly. Thrombocytopenia is common in 50% of patients, but they have less bone problems. They have joint collapse later on, osteonecrosis, osteopenia, and they develop Erlenmeyer flask deformity maybe later in adulthood. That one is the perinatal lethal Gaucher disease, is a severe form. They consider it as one type of type 2 Gaucher disease. The presentation is usually with non-immune hydrops fetalis, with the shiny peeled skin. You can see the peeling here, and you can see the shiny skin, and there is joint problems too. The most common dermatological manifestation are colloidal skin, ichthyosis, desquamation, petechiae, and purpura. Dysmorphic feature as well is there, and the cardiomegaly with the small thorax and lung hypoplasia that lead to respiratory distress is common. Hepatosplenomegaly and pancytopenia, arthrogryposis due to bone deformity, joint deformity, and stiffness. Also neurological, progressive neurological deterioration like seizure and hypotenus, obocytenus is common, and those are the mutations that cause this kind of Gaucher disease. There is diagnostic algorithm in adult. Actually, I get this from a published paper in 2020 by Hazimi et al. About how to approach patient with Gaucher disease. You can go through it. It's in this journal of applied hematology. In pediatric age group, once we catch a patient who is suspected to have Gaucher disease, like with huge splenomegaly and hepatomegaly, with anemia and thrombocytopenia, we usually go immediately for enzyme assay, actually, because it's more rapid and it can give you the results within few days. After that, if it is confirmed that there is lack of acid beta glucosidase, we proceed for molecular testing, whole exome sequencing usually. We don't use panel nowadays for a lot of reasons, but this is now not the time for discussion about it. But whole exome sequencing, and when we confirm it but by molecular testing, usually we always refer the patient and his family for genetic counseling, and the genetic counselor usually they do target mutation to screen for carriers, and this will catch the cases before they become symptomatic, and this will, it's good to start treatment even before they become symptomatic. The next step is to start the patient on treatment. We have two modalities, two treatment available, but we have two directions that treatment. One to support the patient and to treat his symptoms, and the other one is drug-specific treatment. So supportive measures for the patient would refer to subspecialties, including orthopedic, neurologist, ophthalmologist, and starting some medication to support his bone is very important. Disease-specific therapy, like which is enzyme replacement therapy mainly, and substrate reduction therapy. The enzyme replacement therapy, we have several kinds created by the recombinant DNA technology. We have amylglycerase, which we are using it now from Chinese hamster ovary cells. We have another type from human fibrosarcoma cells, and we have the genetically modified carrot cells. They use carrot cells and they produce they manufacture this enzyme replacement therapy. It's administered intravenously once every 2 weeks, And it showed a lot of improvement. It increased platelets count, hemoglobin concentration, and it reduced spleen and liver volume, as well as it improved skeletal manifestation, the manifestation like bone pain and crisis. Overall, it improved the quality of life, and generally it's well tolerated. The substrate reduction treatment work on the reverse reaction of the disease. When the beta-glucosidase is deficient, there will be accumulation of glycosyl ceramide. And there is a reverse reaction where it combines ceramide with glucose to form glucosyl ceramide. The substrate reduction therapy work on this stage, and it partially inhibit glycosyl ceramide synthetase, and reduce the substrate in the blood, reduce glycoceramide accumulation in the lysosome, as well as reduce the formation of Gaucher cells, and as a result, it will alleviate clinical manifestation of Gaucher disease. This is the regular assessment which the patient should go through, whether he started on enzyme replacement therapy or not. And you can see for those who started on enzyme replacement therapy, you have to monitor their blood tests every 3 months. But the rest, like the visceral enlargement and then the skeletal abnormalities, you can do it every 1 year. And if the patient achieves therapeutic goals, you can space it and you can do it every 2 years. So there is a lot of comorbidities and complication of Gaucher disease type 1 that may complicate treatment. They might develop neuropsychiatric disorders, mainly Parkinson's disease. They are liable to develop different kinds of malignancies, metabolic disorders like insulin-resistant diabetes, cardiovascular problems, and immunological disorders, gastrointestinal disorders as well. So you have to be very careful, and you have to keep your eyes closely on the patient's clinical manifestation and refer him to the proper subspecialties. Break. I know no time for break. This is case. I finished case 1. This is case 2. Case 2 is one of my patients. She's 3 years old Saudi girl, product of full-term normal spontaneous vertex delivery without complication. She was referred to from a Zulfi hospital with abdominal distension for 7 months due to enlarged liver and spleen. And she had mild motor delay, mainly walking, but she was able to sit without support, and she was able to speak. Since November last year, she started to have recurrent respiratory difficulty because of pneumonia, worsening cough and sputum, and oxygen desaturation reached down to 73%, and it progressed her pulmonary situation until she became oxygen dependent. Now she is at home with oxygen through nasal cannula. Regarding her family history, the parents are first cousins, have one older healthy sibling, no similar case in the family, and the patient was referred to me because she has dysmorphic features and abdominal distension with hepatosplenomegaly to rule out metabolic disorders. On examination, she looks unwell, not distressed, but she was on oxygen through nasal cannula. She has her weight was below 5th centile, but her height was okay. She was dysmorphic. Mainly, she has coarsening of facial features. I couldn't bring her photo because the parents did not agree, so I brought similar case from online. And you can see the abdomen, how it is distended. She looks like it exactly, like this picture, photo. The chest was okay, but there was transmitted sound. Cardiovascular system was unremarkable, and the abdomen was so distended with hepatosplenomegaly and severe the splenomegaly. The span was 12.5 centimeters by ultrasound, and CNS examination only she had mild hypotonia but normal reflexes. Investigation, CBC was okay apart from leukocytosis because at the time of admission she had pneumonia. And she had elevated liver enzymes as well. Skeletal survey showed J-shaped sella turcica. It showed also severe narrowing of the nasopharyngeal airway because of tonsillar adenoid enlargement. And she showed the typical finding of Erlenmeyer flask deformity, which appear because of metaphyseal expansion in the lower part, in the distal part of the femur. And you can see it in adult too. Chest X-ray showed bilateral diffuse interstitial opacity, suggestive of interstitial lung disease. Abdominal ultrasound showed hepatosplenomegaly with enlarged liver and splenomegaly of 12.5 centimeters. We proceed with this whole exome sequencing, and the result was showing homozygous pathogenic variants in BD1 gene. That confirmed the diagnosis of autosomal recessive Niemann-Pick type AB disease. The concentration of the biomarkers was so high too because the patient was not treated yet. So Niemann-Pick disease, it is an old name. It's well known that there is a disease called Niemann-Pick disease. But now they replace it with another name, which is acid sphingomyelinase deficiency, or ASMD, and I will tell you why. It's a group of rare autosomal recessive lysosomal storage disorder associated with splenomegaly, variable neurological deficit, and storage of lipid, including sphingomyelin and cholesterol. And it was first described by Albert Niemann. It's a German pediatrician. It was in 1914. Later on, a histopathologist called Pick, he emphasized more on the histopathological part, and that's why they named the disease as Niemann-Pick disease. And the gene responsible for this disease is the SMPD1 gene, which localized on chromosome, the short arm of chromosome 11. So, when they describe Niemann-Pick, they include, there is Niemann-Pick C, but they found that it is due to a problem in the cholesterol transportation inside the cells, so they exclude it, and they concentrate on A and B, and they call it ASMD. So, sphingomyelin, in this situation, if there is problem in the sphingomyelinase enzyme, it will lead to accumulation of sphingomyelin, and it will accumulate mainly in very vital organs like spleen, liver, brain, and lung. And this will damage the tissue and cause all manifestations of Niemann-Pick disease. Also, the ceramide will reduce ceramide. The ceramide is very important in inflammation and apoptosis. It functions as signaling molecule in other cellular processes like autophagy, cell cycle arrest, and differentiation. There are three types, actually two types, A and B, but there is intermediate type. They call it, it's an overlap between the clinical finding of A and B, so A and B, and B. The A is a rapid progressive disorder with neurological manifestation, and the onset is early, in early infancy. The life expectancy is short, and the main cause of this is respiratory failure and multisystemic failure. For type 2 is AB, it's intermediate, and it characterized with multi-organ involvement. The onset is a little late, life expectancy is variable, and the leading cause of this is respiratory distress, liver disease, or as a liver transplant complication, and neurodegenerative disorder. For type B, which is the most prevalent type, it's a chronic one, and there is no neurological involvement in this type. The onset is late in infancy and adulthood, and the patient can survive up to the 2nd or 7th decade of life. And the usual cause of this is respiratory distress, liver disease, bleeding, and remember, there is no neurological involvement in this type. There is genotype-phenotype correlation. I will not go through this slide. Maybe it need more time to emphasize it, but type B has specific genes related to it, and type A as well. The current management for Niemann-Pick disease is symptomatic treatment, also lifestyle change. Multidisciplinary team care is very important. Most of the patients, they needed albuterol for difficult breathing, need extra immunization like flu vaccine and pneumococcal vaccine. For their lung problems, statin, which to control their high cholesterol, and they have to change their lifestyle style. They have to be away from contact sports because of the high risk of spleen rupture. They have to control their diet to manage the GI upset and reduce the activity because they have easy fatigability. There is a treatment coming in the way, but we are waiting for the approval by the Saudi FDA. It's an enzyme replacement therapy. Inshallah, it will be soon with us in the market. So, in conclusion, massive hepatosplenomegaly may indicate a storage disorder rather than malignancy, even in adult age group. Early diagnosis and medical intervention of the storage disease result in better outcome, and referring the family of an index case for genetic counseling and prenatal testing facilitate early diagnosis to prevent recurrence of the disease in the family. Thank you.
Thank you very much.